Good morning, everyone. And on behalf of Screen NJ and the Rutgers Cancer Institute of New Jersey, hello and welcome to this month's edition, I guess, of Community Cares and Project ECHO. Thank you for joining today's session, and we hope that the information shared today will help you serve your community better. And so just a few announcements before we do begin the presentation. If you can please keep your microphones muted during the presentation out of respect for our presenter. Any questions you can enter into the chat box, and then we will go over them at the end of the presentation. And as a reminder, we are recording today's webinar. Quick disclaimer, the information contained in this presentation is not a substitute for medical consultation. A physician should always be consulted for any health problem or medical condition. All logos, text, and images used in this presentation are the property of their respective copyright owners and are used here for educational purposes only. And if you would like to use any portion of this presentation for non-personal educational use, please contact the meeting host or presenter for permission. And then today, this is our agenda. So we'll be going over the Project ECHO series overview. We will do introductions, and I will introduce you to our speaker and case study for today, go through the presentation, case study, and then we will have questions and an answer form at the end of the presentation. So just a little bit about Project ECHO. So the Rutgers Cancer Institute became a Project ECHO hub in 2021. And Project ECHO is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right time and at the right place. And this is done by using technology to leverage scarce resources, sharing best practices to reduce disparities, applying case-based learning to master complexity, and evaluating and monitoring outcomes. And if you would like any more information on Project ECHO, you can visit their website, which is on the bottom right hand of the screen. And now I will turn it over to our presenter for today, Valerie Shander. Whenever you're ready, Valerie.
Thank you for having me. So I'm a nurse practitioner that works currently in the breast and GYN oncology space at Rutgers Cancer Institute. But I also have started a high-risk program working for those patients and trying to help patients who do not have a breast cancer diagnosis or GYN cancer diagnosis, and how to streamline them through and making sure that they're monitored appropriately, and if and when a cancer diagnosis is found, or if they want to do anything further, they're navigated to the right appropriate places. I have a certification in genetic research, along with a oncology nurse practitioner certification and a family nurse practitioner license. Next slide. So again, we're talking about navigating genetically predisposed individuals today. I'm mostly focusing on breast and GYN cancers because those are my primary focus, but I will touch on pancreatic and colorectal cancers too. Next slide. So our objectives: describe the correct way for a patient to navigate appropriate screening if they're at increased risk for cancer. We're going to identify correct screening tools based on genetic mutations, and describe understand screening and risk reducing strategies for people at risk. Next slide. So this is our pre-test, and then we'll do follow-up questions, but if you could answer the 4 questions, and then we'll go over them at the end. So first question: only patients with a genetic mutation need increased screening for cancers. True or false? Second question: every patient with a family member with a breast cancer diagnosis should have a breast MRI. True or false? Third question: having an MRI means you do not need a mammogram. True or false? And everyone with a mutation needs to have a mastectomy. True or false?
Let's give it about another minute. Okay, it looks like we've hit our maximum.
All right, so next slide. So this is just a slide marking who is at risk for cancer. So when we look at cancers, we can't just say certain things are for certain cancer or for all cancers. Each cancer has certain risk factors. So the one to the farthest left is pancreatic. So if you're a smoker, if you're between the ages of 60 to 80, if you consume excessive amounts of alcohol, if you have a recent diagnosis of diabetes, or pancreatic pancreatitis, it can put you at increased risk. Obesity also puts you at increased risk, along with certain foods that people may eat put you at increased risk. Regards to breast cancer, obesity again puts you at increased risk, along with older age, being female gender obviously puts you at increased risk. Previous exposure to radiation, so especially patients who have had childhood radiations for lymphoma, may put them at increased risk for breast cancer, along with alcohol, hormone use, and genetic mutations. In regards to ovarian cancer, if you've had children after the age of 35, or a history of endometriosis, history of infertility, particularly if you've had to do infertility treatments, later menopause, and genetic mutations again, along with estrogen therapy, all can put you at increased risk. And the bottom slide is for colorectal cancers, being overweight again, so consistent factors, obesity and overweight, alcohol, smoking, sometimes race can also put you at increased risk, along with your diet and any family history. And older age will also put you at increased risk. Next slide. So ways we can consider who's at high risk. So genetic mutation is oftentimes what we think of. That is just one part of the piece. So yes, people who have a genetic mutation are at increased risk, and we'll go over genetic mutations. And it's not just you have a genetic mutation, you're at increased risk. There's different percentages based on which mutation you have and what cancers we're looking at. But genetic mutation does put you at increased risk. Other part is family history, and more specifically than just family history, some people will look at distant relatives. It doesn't matter as much about distant relatives as the closer relatives. With or without a genetic mutation, family history does have a factor. And we look at something called a Tyrer-Cuzick score. And Tyrer-Cuzick score is not just looking at family history, but it's looking at other factors. And again, we're going to go over it in more detail, but it looks at when you had your first period, when you went through menopause, have you ever had any biopsies? There's different factors that we look at. And based on what your Tyrer-Cuzick score is, it will dictate, should we do more advanced imaging? So when a patient comes to me and they have no genetic mutations, or they've never been to a genetic counselor, I put them in a Tyrer-Cuzick score and see what their number is. And based on what their score level is, it will then dictate a discussion about what should we do? Should we do further imaging? Should we do certain things? It will help have that conversation. So it's part of how I have that conversation with patients. And then the other factor that puts people at increased risk that I touched on is exposures. So exposures in childhood, especially those childhood cancers and the childhood cancer survivors, that we did all these treatments when they were 15 to 20 to even into their later 20s, puts them at increased risk for new cancers. So again, lymphomas can put you at increased risk for breast cancer when we've done radiation to your chest wall. And we'll again touch on more details in the future slides. Next slide. So Tyrer-Cuzick score, it calculates out both your 10-year risk along with your lifetime average risk. So it looks at your specific 10-year risk along with someone who is at the exact same age as you and their 10-year risk. It also looks at the average lifetime risk. So maybe your 10-year risk is only 5%, but your lifetime risk is actually at 30%. So it kind of can figure out, are you really going to be at risk for breast cancer in the next 10 years, or are you really going to be at a risk for your entire life? Again, it looks at your family history, your first menses, when you went through your first period. When did you have your first child? Did you have your first child at 25 or did you have your first child at 35? And it seems arbitrary to most of us, but it does make a factor in when you're going to have a breast cancer diagnosis. Doesn't matter when you had your last child, but that first child is what matters. Prior biopsies, that can also matter. Especially if those biopsies were a high risk biopsy. So if you had a biopsy and it was negative, it doesn't matter as much as if you had those atypical cells. So it wasn't a cancer, but you had something that was a little suspicious. So pathology is important that we look at while we're doing these. The density of your breasts. If you have more dense breasts, that also can be a factor. And I'll go into the density and why that matters in a future slide, but density does have a factor into your risk overall of a breast cancer diagnosis. Not specifically because a density causes a breast cancer, but it makes it harder for us to sometimes see a breast cancer. Your height and weight is also put into the calculator. So if you're again obese, it will put you at increased risk. Your current age, so again, it's comparing you to other people, along with if you're 35, maybe your 10-year risk is not that great, but if you're 60 with that same family history and everything else, your risk may be greater for that 10 years. And then any hormone use. So if they were using oral contraceptives or they use fertility treatment, those factors can also dictate their risk. Next slide. Genetic mutations. So again, not all mutations cause the same risk factors for cancers, and not all mutations predispose you to all cancers. There's all sorts of different mutations, all sorts of different cancers. Some have affect multiple cancers, some only affect one cancer. And based on what mutations, we also will determine what screening tests we use. So we don't, again, use all screening tests on all patients. We cater each patient and each genetic results and each discussion with each patient's family history. So, you know, when we're having that discussion, if a patient has a genetic mutation and has a family member who had a breast cancer at 35, it's going to dictate me differently than all their family members had breast cancers in their 60s. So looking at the full picture is very important, not just they have a genetic mutation. Next slide. So this slide looks at childhood cancer exposures a little more detail. So if someone has received total body irradiation, they're at increased risk for secondary malignant neoplasms. If they've received cranial or craniospinal radiation or abdominal or pelvic radiation, they're at increased risk for colorectal cancer. So just being mindful of where they had their radiation is important, not that they just had radiation, but where was it exposed? Again, the chest radiation, you're at increased risk for breast cancer. If they received any alkylating agents, so certain chemotherapies, especially in childhood, you know, and now they're in their 50s, that exposure that from far along, so it's been 40 years since their exposure, puts you at increased risk for AML, so acute myelocytic leukemia or a myelodysplastic syndrome. So something with their bone marrow is not working properly because they received chemotherapy in the past. So just being very mindful of those childhood cancer exposures, because oftentimes we don't think of it because sometimes they won't even mention it since it's been so far removed. I've been cured for 35, 40 years, but those are the ones we have to be extra careful of because it's been so long that sometimes these things show up now. Next slide. So mutations, there's all sorts of mutations. It's just demonstrating that a mutation doesn't mean just one thing. We can have all sorts of different ways that a cell or DNA can mutate. You can have substitutions, deletions, inversions, insertions. So I'm not a genetic counselor by any means, but you know, there's all sorts of things that we need to look at when people are having these mutations and how that can affect them. Next slide. So here's just some of the mutations. So I included some, but you know, we think of BRCA mutation and we think that's the only one, but there are a lot of different mutations. So again, each one has its own different risk factors, different things that we need to monitor. Oftentimes patients will come to me and say, I was tested for BRCA and I was negative. So sometimes that means they were just tested for BRCA, and sometimes they use that as a general term for genetic mutations. So it's always good to get the actual report of what mutations they were tested for. It also determines, it sometimes can be dictated by when they were tested. You know, when we were testing people in 2010, 2012, it really was BRCA1 and BRCA2 mutations, and that's all they were tested for, because that's all we really knew. Since then, we've discovered that there's all these other mutations, and they dictate for different patient populations. BRCA1, BRCA2 is very commonly found in an Ashkenazi Jewish population, which is great if you're Ashkenazi Jewish, but if you're Italian, if you're African, if you're Mediterranean, if you're Black, it can be very much different mutations that you have. And so again, looking at the individual, looking at what they were tested, was it a full panel or was it very narrow? When was it tested? Even if it was tested in 2012, 2013, and it was a full panel, sometimes our panels have changed since then. So making sure that they're seeing a genetic counselor, making sure that their panel is up to date is important. Next slide. So this is looking at the mutations. And again, not all mutations cause all the same risk factors. So I put it in, and I don't know how easy it is to see, so I apologize if it's hard to see, but I thought it was important to see how each mutation can affect each cancer type. So the first panel is breast cancer. Second is ovarian, pancreatic, and prostate cancer. And it's looking at breast cancer risk. So the blue color is ATM mutation. So with the ATM mutation with a breast cancer diagnosis, your risk factor is 20 to 30%. Orange color is BRCA1. And someone with a BRCA1 mutation has a risk factor of about 60%. BRCA2 is the gray color. So that is also about a greater than 60% risk for a breast cancer diagnosis. CHEK2 is that yellow color. It's about 20 to 40%. So I put it at 20, but it's somewhere between 20 to 40% risk factor. A PALB mutation, also for breast cancer, is 41 to 60%. PTEN is 40 to 60%. But that same, mutations in a ovarian cancer risk, ATM is only 2 to 3%. So yes, ATM is a high risk for breast cancer, but we don't really have to worry too much for those patients in ovarian cancer. Where BRCA1 mutation is 39 to 58%. So a BRCA1 mutation for ovarian cancer is a high risk mutation. So they need to be thinking about things differently than an ATM mutation. BRCA2, which has just the same risk for BRCA1 in breast cancer, in ovarian cancer, it's only 13 to 29%. So even between a BRCA1 and a BRCA2 for ovarian cancer, you have to look at them differently. CHEK2, no established risk factor for ovarian. PALB is only 3 to 5%, and PTN in ovarian is not established either. So again, looking at things differently. And with the pancreatic, most of these mutations are 5 to 10%. So depending on their family history, you may not have to do much, or we may have to have them see the GI specialist depending on what is going on with them. And then prostate cancer, I also put in there with the ATM. It's not really increased risk, and the BRCA1 is 7 to 26%. BRCA2 for prostate is 19 to 61%. Next slide. So what dictates how we treat them, how we see patients with certain mutations? So I always, when I'm seeing a patient with any mutation, I pull up the NCCN guidelines. So what is that? That's the National Cancer Comprehensive Network. So any patient with any mutation, I pull this up. I print them out a copy of it so that they can see exactly what their risk factor is for that mutation, along with what is the recommended recommendations for that mutation. So what is it recommended to do for a BRCA1 mutation for a breast cancer risk, ovarian and pancreatic? And then we sit down and we go over it and we say, what is the recommendations and what should we do for your individual case? And then have a discussion if they want to proceed with certain things or they don't. So it doesn't have so much the guidelines of what to do on this particular slide, but again, this is just telling the risk factor, and then you go in further. I think it's like page 45 tells you exactly specifically for a BRCA1 mutation of this like 100-page document, what you should be doing for that specific guideline. So how often you should do MRIs, how often you should do mammograms, should you consider surgery? It tells you all that right there. It's, and then you have that informed conversation with the patient. Next slide. So what should you do with a patient with high risk? So refer to the National Comprehensive Cancer Network. So again, those are the guidelines. Those are the recommendations. They give you at least a tool to help you dictate that conversation and let the patient know what is safe and what's best for them. If a patient has no genetic mutations, again, we use the Tyrer-Cuzick score. Anything greater than a 20%, they should consider a mammogram alternating with an MRI every 6 months, along with a clinical breast exam every 6 months. So seeing myself potentially in a high-risk clinic, and then seeing a GYN or gynecologist 6 months later for a regular exam. Obviously, sometimes if things need to be repeated every 6 months, so if their mammogram needs to be followed up in 6 months, that may get them off schedule, but ideally something should be imaging them every 6 months. They're high enough risk that if we let them go a full year without any imaging, that we might be missing something. Again, it's an informed conversation. MRIs have their own risk factors, own pluses and minuses. We'll go over it a little more detail in another slide. But, you know, MRIs are not meant for everyone. There's a reason why we don't give it and we don't make it a standard of care. We need to make sure it's catered to that specific patient. So having an informed conversation, what is the risk factor of going forward with the MRI? Are you aware of those risk factors? Are you okay with it? We don't just blindly go forward with an MRI, make sure that they're aware of what they're getting themselves into. The other thing is having to make sure that they're having a healthy diet, they're exercising, and they're reducing any alcohol and cigarette consumption. It's not perfect. We have people who are on a perfect diet and exercising and not smoking and not drinking, and you still can have cancer, even without a genetic mutation. But you might as well reduce your chances and make you as healthy as possible if you can. So, you know, having that conversation about healthy diet, helping them with a nutritionist if they need to, or whatever they need to do to make sure that they're as healthy and at as decreased risk as they can be. Next slide. So again, what is the MRI? So an MRI is different than a mammogram. It's a different way of looking at breasts. So we look at it with magnetic resonance imaging. So mammogram, we're switching the breasts and we're kind of pushing the tissue so that we can see through the tissue. MRI is looking a different way. So sometimes it's a good tool if people have really dense breasts. So it's dense breasts are that they have different type of tissue. So their tissue is so firm that it's hard to sometimes see things through a mammogram. You know, we can switch and sometimes we can find things, but sometimes the density can prevent us from seeing things that could be hidden in there, especially a small breast cancer. MRI can kind of go through the noise and see what's behind everything. It's non-invasive. It doesn't give patients radiation. So that's always good to know because some patients, you know, get fearful of mammograms because we are giving them radiation. It's a necessary evil. It's smaller dose than if you're going through a X-ray machine for going through security, but it is still giving you some radiation. MRIs do not give us radiation. It is an expensive test, so insurance do not like to pay for it unless they know that you are a higher risk patient. So having your Tyrer-Cuzick score on your MRI imaging order does help to get you approved, along with the fact that you have a genetic mutation. Still doesn't always get approved, but it does help insurance companies to sometimes approve them a little easier. They will not again approve it for anyone greater than, unless they're greater than 20%, a Tyrer-Cuzick score. So if your score is 15%, doesn't matter what you think that you should be getting it, they probably won't pay for it, and it's expensive. Patients do have to lie on their stomach for about 40 minutes. So people who have back injuries or have issues just lying on their stomach are not going to be able to do this test. It does have some claustrophobia, but people often will tell me that claustrophobia is easier with the MRI because you're lying on your stomach. So rather than staring at the machine when they're on for MRI of their back or their head, people do find it easier, but they still sometimes need an anti-anxiety medicine to get them through the procedure. The other problem with MRIs, and this is usually part of my discussion with them, is it can have a high risk of false positives. And what that means is sometimes things will look suspicious when they're truly nothing, and then we have to put you through a biopsy. However, if they're negative, they're truly negative. They don't give us false negatives. So it does give us that confirmation if things are truly negative, but if they're positive, it sometimes can be hard. If they're still getting their menstrual cycles, we also want to time them with their menstrual cycles. It's usually day 1 is the first day of their cycle. We do it day 6 to 16. If we do it outside that cycle, sometimes we get more noise and get more false positives. And then we're putting people through biopsies that we don't want to be putting people through. A biopsy for MRI is not as easy and as pleasant as an ultrasound guided biopsy. it's a long procedure. So it's usually 2 to 3 hours to do an MRI biopsy because they have to put you in the machine, find the spot, take you out of the machine, mark the spot, put you in the machine, find the spot again, take you out of the machine, biopsy it, put you back in the machine, make sure we got the right spot. So it's a long, tedious process. So again, you don't want to be putting people through it unless you know what you're getting yourself into. And for patients who are higher risk and they have watched their family members, it may be worth it to them, but it's informed conversation. Next slide. So this is looking at breast MRIs. So it's showing you what the machine looks like. It's also showing you example on the left side of enhancing breast tissue. So the enhancing breast tissue is an area of concern versus the bottom green area, which is the normal breast tissue. So it looks a little bit different. I'm not a radiologist, so I can see it looks different. I can also see an area of kind of increased density, kind of in the red circle area. But it's something that the radiologist would probably give it a BI-RADS 4. A BI-RADS 4 is something that looks concerning, but not super suspicious for breast cancer. All of our imaging is rated BI-RADS 1 through 6. BI-RADS 1 is everything looks completely normal. BI-RADS 2 is it still looks normal, but there are some normal kind of findings within the breast. BI-RADS 3 is there's something there. It's probably benign. We just need to watch it. So oftentimes those are the people who we have to do imaging again in 6 months. A BI-RADS 4 is there's something suspicious. It's not, it might not be a cancer. It might be a cancer. We can't really tell, but we probably should biopsy this thing. A BI-RADS 5 is this looks like a cancer. You need to stick a needle into this right now. And a BI-RADS 6 is we know this is cancer. So radiologists will give us ratings and will help us to dictate, again, should we biopsy it? Should we send them to surgery? What should we do with this finding? So it's important the radiologists give us those BI-RADS scores. Next slide. This is the image of density. So again, people often think that they're at increased risk because they have a breast density. It's not that they're at increased risk for a breast cancer. They're at increased risk for having something being missed if they have a breast cancer. So with the black and white pictures, you can see this is the far left is just a fatty breast. That's a normal breast with just fat tissue in it. And as you go further over to the right one is extremely dense. So imagine if you have a small little area of either calcifications or a breast mass, it's very hard to see within it. All you see is a big cloud of puff. And so again, the density does not mean that they're going to get breast cancer. The density means it is very hard for radiologists to see behind the cloud of puff to catch a breast cancer. Because you're not worrying about the breast cancer that's so large that you can feel it. Those we could see through a mammogram too. That would make the cloud of puff kind of separate. But a small breast cancer won't. A small breast cancer we won't feel. We're using the mammogram to catch those things. So sometimes we use ultrasound to help with it, but sometimes we need an MRI to help really get through the cloud of puff. Next slide. So this is just a little background to the high-risk clinic here. And this can be done pretty much anywhere. Most clinics do similar kind of concept. Patients are referred to the genetics department, or they can be referred directly to our high-risk program. So sometimes patients come to me through the genetic counselors, and sometimes they're either referring themselves or their primary care gynecologist are referring. Either way, I see patients both for genetic mutation and for family history, or some patients who are just nervous and just want to be seen. My thought is that if it would make you feel better, we can see you, especially at this time. I'm not overwhelmed where I can't say yes to everyone. So I say yes to anyone who just wants to be seen and feels more comfortable being seen. If they have not seen a genetic counselor and they have never had genetic mutations, I will discuss with them, but it does not mean that you need to see a genetic counselor. Not everyone has to see a genetic counselor. Not everyone needs to have genetic mutations done. Some people are nervous about it. Some people say, what's the point? I'm still going to be doing all this. So I don't really want to know if I have a genetic mutation, because sometimes that does open up new concerns, new things. But it is up to every patient whether they want to have that information or not. If they are found to have a mutation, again, I follow the NCCN guidelines to see what we should do next. If they're negative, we follow the Tyrer-Cuzick score and just see what imaging we should do next. Regardless, they have exam. Regardless, we have a discussion, pros and cons of whether they should have any further imaging. Should they have surgery? If they want to meet with a breast surgeon, I set them up with a breast surgeon or a GYN oncology surgeon. Again, depending on age. Sometimes we need them to have their ovaries removed. Sometimes we want to have their breasts removed, but you don't have to have, not everyone needs to have a mastectomy just because they have a genetic mutation. Just because you have a genetic mutation does not mean you have to do what everyone else does. I've had patients who have a breast cancer diagnosis and a just genetic mutation and decide to have a lumpectomy. You can have your own choice. Everything is individual and everything is an informed conversation, but it is your choice what you want to be doing. Either way, again, we see patients every 6 months for imaging and for exam. And usually that's, again, alternated with the gynecologist. So they only see me once a year, but they see someone for a breast exam in 6 months, so that way they're always being examined. Next slide. So again, I spoke on this, it's a partnership. So if they want to see the breast surgeon in 2 years, I will set them up. If they never want to see a breast surgeon, that's fine too. But it's a partnership. So whenever, and I tell this to patients, whenever you choose, or if you ever choose that you want to see a breast surgeon, you let me know, or a gynecologist, a GYN oncologist, or plastic surgeon. We will kind of work together in a collaborative form to make sure that your needs are met. Either way, until you're ready for surgery, we're going to surveillance you and make sure that you're getting appropriate care. Some patients will have an MRI biopsy a couple times and say, never again, I will now have surgery. So some people, it's just a certain point that they come to that realization, or maybe they want to finish having children, or they're 25 and they haven't met their significant other. Whatever point they need to be at, we're here for them. Next slide. So this is just a quick poster that I created. I did a presentation at the recent ONS conference in DC, just talking about the high-risk clinic that I'm doing here, what we're doing. So we've had, this was looking at data from July to February. I had about 23 patients that came through the high-risk program. Again, this is referrals from both genetic counselors and primary cares and GYNs. I try to market it. I made up flyers and different things and trying to talk to people to let them know that this is available. I did find one breast cancer amongst those people. So someone who wouldn't have necessarily had anything done, I found her cancer. And she did not have a genetic mutation. She was just high risk, had a high Tyrer-Cuzick score. We did an MRI and that's how we found her breast cancer. Next slide. So I took a case study from actually a real life person. She is a celebrity. I'm not positive what she's been in, but Olivia Munn. So she's a 42-year-old woman who went through a 90 gene panel for her genetic mutations, and it was found to be negative in February of 2023. She also had a normal screening mammogram in February of 2023, and she went and saw someone, and I don't know her whole family history because she's a celebrity and I couldn't find much out there, but whatever it was, she had a Tyrer-Cuzick score, and I found that her Tyrer-Cuzick score was 37%. So she underwent an MRI pretty much right after her mammogram, about March, April. She had an MRI, it looked suspicious. They did a targeted ultrasound, so they went over that area with an ultrasound probe shortly after the MRI, and then they did a biopsy of both breasts, and she was found to have bilateral breast cancer in April of 2023, only a month or two after her mammogram, which was negative. Her genetic mutations all found to be negative. And she was found to have stage 1 breast cancer bilaterally and had a bilateral breast cancer, or bilateral mastectomies, I'm sorry. So next slide. So takeaway message, just because a patient is negative for any mutations does not mean they're at high risk. So just like Olivia, just because they don't, you have to look at their family history. You have to look at when did she have her first child? When did she have, did she ever have any breast biopsies? She had dense breasts. What other risk factors could potentially put her at higher risk? Some patients need that dual imaging. So not just having, breast exams, but making sure they're having mammograms and MRIs, or mammograms and ultrasound, something to monitor their breasts every 6 months. You want to make sure that they're talking to their healthcare provider about what screening tests are best for them and pros and cons of each test. And follow up if something doesn't feel right. I always tell patients, if you don't feel something is right, even if you can't put your finger on it, just let us know. It's better to let us know, and then we can do further imaging than to just sit on something to your next appointment in 6 months. Just communicate. Next slide. So these are the follow-up questions. So again, true or false? Only patients with a genetic mutation need increased screening for cancers. True or false? Every patient with a family member with breast cancer should have a breast MRI. True or false? Having MRI means you do not need a mammogram. True or false? And 4, everyone with a mutation needs to have a mastectomy. True or false?
So we'll give it about another minute and a half. Giving it just another little bit of time. Okay. Valerie, if you want to review the results, we can.
Sure. Can I see them? Oh, there they are. All right, so only patients with a genetic mutation need increased screening for cancers. So 12% said true and 88% said false. This is the post-test, okay. So genetic mutations need increased screening for cancers. So the answer is false. So if you have a high family history, if again, you've had post radiation for childhood cancers, any of those things, we should be doing further imaging. Again, using the Tyrer-Cuzick score or just looking at the childhood risk. So if someone has had post-radiation in childhood, they qualify for MRI too. So it doesn't have to have a high Tyrer-Cuzick score in those childhood cancers too. Number 2, every patient with a family member with breast cancer should have a breast MRI. 32% said true, 68% said false. So the answer is false. Not every patient should. Again, you want to look at the individual. Even if they have a high Tyrer-Cuzick score, they may have horrible claustrophobia. They may not be able to lie on their stomach. There may be multiple reasons why they can't do it. They may have metal in them that they can't do an MRI. So there's multiple reasons why someone may not be able to do an MRI, but you need to at least have that discussion with them, discuss, why we're recommending it, what we're looking for, how we may miss something if we don't do an MRI. So again, it's an informed conversation, but not everyone necessarily gets a breast MRI. Having MRI means you do not need a mammogram. 3% said true, 97% said false. I realized I didn't even really touch on that, but mammograms are by far the gold standard. So a lot of people will try and get out of them. They will say that, oh, I don't need to do a mammogram. I'm doing an MRI. MRIs are better. It's going to pick up on things from the density, but mammograms are still our gold standard. We're still doing mammograms despite them being a little torturous. We still need to be doing them. Radiologists will often, a good radiologist will also look at the mammogram and use that as tool for looking at their MRI. They're looking at it together. So one of the radiologists I worked with always made sure you had your mammogram up to date. She would not do an MRI if you did not have a recent up-to-date mammogram. She used that as a tool to best dictate how that MRI was read. And number 4, everyone with a mutation needs to have a mastectomy. 9% said true, 91% said false. And this is false. So even if you have a BRCA mutation, does not mean you need a mastectomy. Even if you had a breast cancer diagnosis with a BRCA mutation, does not mean you need to have a mastectomy. Even if you've had 3 breast cancer diagnoses and your BRCA mutation, does not mean you need to have a mastectomy. It is your choice as a person. So we will tell you why we think this is highly something you should do, but it's your choice. So whether you want to have a prophylactic mastectomy or if you want to have no mastectomy in your life, it's your choice. You need to be aware of why we recommend it and what the risk factors are of not doing it, but it's your choice ultimately. And then the last slide is just my information. Feel free to reach out to me if you have any questions or concerns past the lecture. So I appreciate it.
All right, well, thank you, Valerie, so much for a very informative presentation. Now we will take some time for questions. You actually do have a few in the chat. If Evelyn, if you would like to read some of those for Valerie.
Sure. So the first question we got was, does the genetic testing only test for hereditary mutations, or do they also detect spontaneous mutations?
So in regards to mutations, when they're testing it, the genetic counselors will sit down with people and kind of go over their family history. And you can have as little testing as you want or as much testing as you want. I did my own genetic testing, and the genetic counselors were like, do you want every single gene tested? And I said, no, can we just focus and narrow down to what's the most important? So you can do as little or as much as you want. In regards to what you're referring to, you're looking, there's what's called somatic and genetic mutations. So it's looking at genetic mutations. It's not looking at mutations from the tumor itself. So when patients have a breast cancer, their cancer will actually have its own mutations. That's not what they're looking at. So we do that separate testing, but that's a separate testing. So even if someone's had genetic mutations, sometimes we'll test their cancer. That's not looking at this. This is looking at things that you have inherited from your family. So if your mother has been tested and she's negative, and your father was tested and he was negative, there's no point in you getting tested, because if they had a good comprehensive panel, you can't inherit something that they did not give you. But if they never got tested and they do not want to get tested and they have a family history, you can get tested. They always like to test the person who's had the diagnosis first, but they will test someone who is just a family member if that person is either not alive anymore or is refusing to get tested. So you are allowed to have testing just from a family history standpoint.
Thank you. Next question, what advice do you have for patients who want to get screened for breast cancer or any other cancer for that matter, but their doctor is being dismissive or doesn't believe that they need to be screened yet? So we hear a lot of those stories where people get dismissed.
So find another provider, look around, talk, sometimes there's high risk clinics. There's sometimes you just need to find a new person. If someone's not listening to you, you need to find someone who will listen to you.
And then the final, this is a 2 parts. I'll do the first one first. So in the case presentation, why did the patient receive the MRI after a negative mammogram?
Because that's standard. I mean, I wouldn't have probably done her MRI so short after a mammogram. I mean, in her case, it worked to her benefit, but usually I'll do it 6 months later. It's probably because she's a celebrity and she can pay for it out of pocket, because she is. So it doesn't matter what the insurance says. She's probably going to do a 6-month MRI because she can afford it. But standard of care is you only get one a year unless it's an abnormal MRI. So people aren't going to do it one right after the other, because then you're doing 2 images right after the other. But a normal mammogram does not dictate a normal MRI, and that's why we use it together. As it's not just you have a normal mammogram, there might be something missing, and that's why we use them complementary. So one and then the other one can help catch something that we may have missed with the mammogram, and that's why we do both.
And then the second part is, do you find people request genetic testing for cancer with no family history of cancer?
So if someone is adopted, that's a perfect example of someone who should go for genetic testing. We don't know what your family history is. Or if their family history, no one's talking to each other and we don't know anything about your family history, but we hear glimmers of there may have been a cancer, or someone died in their 30s and there was no accident, but we don't know what happened, that might be appropriate to go get tested. So you can get tested for those things if you have a family history that you know everyone and you know everyone's family history and there's no cancer, probably not appropriate, and your insurance will reject you unless you want to pay out of pocket, which is expensive.
And then this one just came in, following up on what you say to patients who are being dismissed by their doctor, are there any cancer screenings that do not require an order?
No. I think in some states maybe, but I have only practiced in the Northeast, so I can't speak specifically, but I do have a patient who just came from Arizona and she said she didn't need an order for a mammogram. She could just walk in and do her own mammogram. So I wouldn't be surprised if other states have rules that I just don't know their rules. I just know in New Jersey, you can't do anything without a nurse practitioner, PA, or a doctor's order. Even a nurse writing your mammogram order is not going to fly.
Well, we have actually colleagues from other cancer centers on the Zoom every once in a while. And so if any of you from other cancer centers throughout the country, if you're able to do, you know, what Valerie just mentioned about mammograms, somebody can just walk in and get a mammogram, feel free to put that information in the chat. And then I have another one. A 65-year-old woman with no family history of breast cancer should get a mammogram or MRI, and how often?
So she should get a mammogram if she has no family history and no other high risk factors, no childhood cancers, nothing that puts her at a higher risk for Tyrer-Cuzick. Again, you know, I'd have to look at her entire case to be able to fully answer. She would be probably just a mammogram. So, and she would just get a mammogram once a year unless the mammogram's abnormal. So if her BI-RADS score was a 3, she would get a mammogram again in 6 months. If a BI-RADS 4, then we'd probably do a biopsy, and then we may do further imaging if she had a higher risk, you know, BI-RADS mammogram, but it depends on her individual case. For her specifically, just based on that, I would probably just do a once-a-year mammogram with a clinical breast exam once a year.
And then one of our colleagues from New York commented that it depends on the radiology practice. Their mobile mammogram does, sorry, the icons are blocking. Sorry guys. I think it does not require a script, and they're in New York. Does not require a script. And another one confirmed New York State, no script required for mammo on mobile van, but need script for brick and mortar. So there are different rules. If anyone has any other questions or comments, feel free to unmute yourself and ask the question directly, or you can also pop it in the chat.
Well, I actually had a question, Valerie.
Sure.
So if let's say you were to get like a diagnosis of, you know, breast cancer or anything like that, could you kind of go through like maybe some of the different options? Like you said, something like a lumpectomy versus a mastectomy. You know, are there things where it doesn't have to be a full? Could it be a partial? I didn't even know that there were certain variations that you can get versus going to the extreme and having, let's say, like a double mastectomy.
Yeah, so it depends on your pathology. It depends on how big your cancer is, if it's an earlier cancer versus a later cancer. Most people will not get mastectomies. Majority of people are now lumpectomies. The reason being is studies have shown that a mastectomy versus lumpectomy plus radiation are equal survival. So you don't need to have your whole breast removed. You can do a lumpectomy, take the area of concern out, and do radiation to that breast, and your survival is just the same as if you took your whole breast off. So why take your whole breast off? Have, you know, for a woman, that's a very significant part of your body. It affects your way you perceive yourself, affects how you view life. It just, everything, your sexuality, everything is affected by that. So people will feel very uncomfortable and feel like almost at a loss if they have a mastectomy. They also can do reconstructive surgery at the time of the mastectomy so that you wake up and you have a breast. So oftentimes people will do the same thing. They'll have a plastic surgeon at the same time as their breast surgeon, reconstruct a breast at the same point so that when they do wake up, they feel normal. It may not be perfect, but sometimes they'll have something there so that there's something that makes them feel comfortable. It depends again on what's going on, what their stage is. Some people, because of other factors such as smoking and other things, they just want the breast removed, because if you have smoking, you can't necessarily have reconstruction. So it varies, but yes, depending on their pathology, sometimes we do chemo up front, sometimes we do chemo after, sometimes we don't need to do chemo at all. There's a whole bunch of different factors depending on everything that goes along with their cancer diagnosis.
Awesome. Thank you so much. Any last minute questions, Evelyn, in the chat or comments?
I did see that it looks like in both Carolinas, people can get, and in Oregon now, you don't need a referral or order for to get a mammogram. In Oregon, you do have to be 40 or older. So there are definitely other states where people can just walk in and get a mammogram.
And that probably does not include an MRI, because MRIs, I'm sure that they all kind of fight you on making sure you have an order for that.
Okay. Interesting. All right, well, if there's no other questions, again, I just want to thank Valerie for a wonderful presentation, very informative. If you do have any further questions, you can go through our Mighty Networks resource page. If you'd like to post questions there, if Valerie doesn't mind, maybe we can reach out to her sometime in the future, maybe have those questions answered. And before we end the presentation, I'm just going to go through a few announcements. So in our state, we do have New Jersey SEED, or the New Jersey Cancer Education and Early Detection Program. And it's a program run by the New Jersey Department of Health in collaboration with local agencies and healthcare systems. And the NJSEED program provides education and in the community, different types of cancers. They provide free screenings to those that are unemployed, underinsured, uninsured, or face barriers to getting the cancer screenings that they need. And the NJSEED program currently provides screening for breast, prostate, cervical, and colorectal cancers. And the program is offered in all 21 counties throughout our state. And again, thank you for attending today's session. We would really appreciate it if you could please use the link or the QR code that will be dropped even in the chat to let us know how we did. Please give us our feedback, anything we can improve on, or any topics that you're interested in. And Evelyn will drop that in the chat as well. And then after the presentation, do give us about 2 weeks to finalize our recordings, our resources, and then we do post them in our Mighty Networks community. So if you have any questions or if you'd like to access those materials and resources, please join our community. You can register online or through the link in the chat as well. And then just as a reminder, next month's topic for our ECHO will be cancer caregiving burnout. If you already received these reminders, great. We will see you in July. It's actually crazy to think about. And if you know anybody else that would, like to be a part, feel free to send them our information, and we really hope to see you there. And again, for any additional information or any questions, please feel free to reach out to us. And if not, everybody enjoy the weather if it's nice and sunny and warm by you, and we will see you next month. Thank you again, everyone.